Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast today. My name is Terry Fletcher. So I wanted to go over some things today that I'm noticing on some audits that I'm doing that you could find yourself in a little bit of hot water if you're not clear on who your providers are. So let's take a look at this and make sure that you're clear that you're not using medical assistants, LVNs, LPNs, and RNs as your qualified healthcare professionals, and that you're following the rules of what CPT says, which is the American Medical Association, and then also Medicare. So in 2013, the AMA established a definition for what a QHP is, or what they call Qualified Healthcare Professional. So it's a physician or other qualified healthcare professional. They're qualified by education, training, licensure regulation, and facility privileging when applicable, who performs a professional service within their scope of practice and can independently report that professional service. That's a big key. Think about an RN, think about a medical assistant, an LVN, an LPN. Can they bill directly even for a nurse visit? They cannot. So they are not considered QHPs, and they cannot bill for anything except for they can report a 99211 under the physician. But do not use an RN or a medical assistant as, let's say, a nurse practitioner. That's not appropriate. So remember, QHPs are distinct from clinical staff, because clinical staff, those are mostly comprised of employees or leased or contracted staff that, again, work under the supervision of a physician or even a QHP, and they're more of an assist in the performance of a specified professional service, or blood pressure check, or they're doing something that's to help out. They're mostly standby helpers who are helping to provide a service. So they do not individually report a professional service. Now, there's payer-specific policies also that affect who can report specific services. And clinical staff, again, include medical assistants. They could be licensed practical nurses, registered nurses. But I see so many practices using registered nurses or RNs as, nurse practitioners. And that's not okay. Now, the hospital, they do bring in, a lot of nurses, frontline workers, but that's billed under facilities. So that's a little bit different. They're not billing out specific services for themselves. So what would be specific QHBs? And so when we're QHP, So nurse practitioner, NP, clinical nurse specialist, CNS, physician assistant, PA, certified nurse midwife, they also fall under that, CNM, certified registered nurse anesthetist, and I always have problems saying that, anesthetist, CRNA, clinical social worker, CSW, and physical therapist. So these are providers that can bill directly, and that they are licensed, they're certified, and they meet not only the federal guidelines, but they meet educational training and professional standards of conduct set forth by your state licensing authority. So you're not just looking at what Medicare says, but you're looking at their scope of their license in their state, because there's specific specialized areas of competence that they have to demonstrate within their licensure before they can even get their certification. So the physician is board certified and has certain level of training, and you have the same thing with certain nurse practitioners and PAs, etc. So whenever we see something that it says, I was recently in a practice where they kept saying, my nurse is coming in. Well, patients think that's really a nurse when it's an MA. That's a problem. Or when they try to say, okay, well, this is, Dr. Robert, when actually it's not a doctor, it's a PA, which again, a PA is fine, but you need to be clear who's providing the services, because you don't want to lie to your patients, but you also don't want to give the inference that a certain staff member has medical decision-making under their licensure when they actually don't. And so you have to be very careful with that. So looking at some state regulations at a glance here, just so you know, they're very complex. They're sometimes hard to find, and they're also subject to frequent change. So there's some conflict sometimes with federal rules and regulations and then what they do at the state level. So in all 50 states and in DC, they all recognize and permit NPs and CNSs to practice, but not always independently. So NPs can in 18 states, but they can't always in every state. So you have to check your state, and you need to look at the American Association of Nurse Practitioners. Then you also need to look at the Federation of State Boards of Physical Therapy jurisdiction, because they'll give you information about licensure requirements for those type of providers. There's also a mid-level practitioner authorization by states. So it's a lot of the prescriptive authority. That's a prime example of differences in practice environments between states. So certain QHPs can do certain things. NPs and PAs, they have prescriptive rights in most states, I would say, I think 48. But these rights are regulated, and they can differ from state to state on what they can actually do from a prescriptive standpoint. Also, the American College of Nurse Midwives, they have some certain things they can do, but Medicaid is a big a payer for them. They can do a lot of services. And then socialworklicensure.org, that's a good one, because even though clinical social workers can bill directly for certain things, and also certain things that have to do with behavioral health, they're only able to bill their specific codes, not E&M services. So there's a lot of things that have to do with Medicare enrollment, the Internet Provider Enrollment Chain, that's PCOS. So know your scope of practice, because I see some of these things and I'm seeing that there's a lot of liberties being taken with practitioners billing for services that is really not that practitioner, and they're not supposed to bill for it. So we have to be very careful with that when I'm seeing RNs trying to be treated as nurse practitioners, or MAs treated as, nurse practitioners as well. And you have to be very cautious that that's not okay, because they cannot bill independently for their services. So I have a coding question today that I thought was actually a really good one. And I'm going to thank Betsy Nicoletti from Coding Intel for this, because I get this question a lot, but I like her explanation. And if you ever join a service, I know a lot of you are my Coding Corner clients. If you ever want to join another membership and join Coding Intel, it's really good, and you get a lot of information. It's not direct access, but you get a lot of information that's helpful. So here's the question that came up for advanced care planning. It says, how much detail do I need to include in documentation for advanced care planning? Now, remember what that is. These are face-to-face services between a physician or their qualified healthcare professional and a patient, family member, and or surrogate in counseling and discussing advanced directives with or without completing the relevant legal forms. But this is basically talking to a patient about their wishes on what would happen in the future should they lack capacity, decisional capacity to make decisions for themselves for their health. So there are things that you can do, because there's codes 99497, 99498, and you have to have at least the first 30 minutes to be able to code for this. But I am finding some people are billing for this incorrectly, so let's see what would be appropriate as far as how much you have to include in your documentation. So you want to document the discussion in enough detail that someone reading the note knows what was discussed. Okay, so an example, if a surgeon performs, a colon resection, you wouldn't bill for the service in the op report saying, I performed a colon resection. We require that the surgeon has to document where they started, the opening, the approach, the anatomy, and the operation itself. Similarly, if a physician or non-physician practitioner, so remember it has to be an MPP, can't be an RN, can't be a medical assistant, so that's why I brought this up. They say, I discussed the end-of-life issues with the patient for 35 minutes. Well, what did you discuss? We want to hear that the clinician added some detail to the note. What was discussed, what decisions were made, if any, questions and concerns, and did you fill out any forms that were given or need to be completed to the patients? Now, that's not required, but it is important that you note it if you did it, because a lot of times patients, let's say they call the ambulance, it's really helpful if they've got something on the refrigerator that they can just pull and say, there's my information. Also, some reminders. Again, this has to be done with a physician and NPP with the patient. Don't count the time in any other service. So it does not include the office visit or any kind of in or outpatient visit. You have to meet at least 16 minutes, so the midpoint, before you get to able to bill 30 minutes. But remember, we don't want to hear anything that says ACP discussions are 16 minutes spent. No. You want to have total time spent, and you want to be over that. Also, you don't want to say greater than 16 minutes. Oh my gosh, I saw that, and Medicare took back a ton of money saying, what are you doing? So you want to make sure that you are clear in that information and what you are actually talking about to the patient. Some of those directives are, not limited to this, but healthcare proxy, durable power of attorney for healthcare. Remember, the durable power of attorney that isn't for healthcare expires. That's just financial once the patient passes away. So you have to have one for healthcare. You need a living will, a medical order for life-sustaining treatment, a MOLTS. So those are some of the directives that they're talking about as far as filling that out. Also, make sure that you're not billing this for every patient that walks into the office. I saw one practice that was doing that, and the patient was 27 years old, there for a cholesterol check. Come on, people, try not to be non-compliant or overutilizing a service just because it's there. It'll catch up with you. Trust me, I'm seeing what the OIG is putting out on some of the things that they're finding, and it's not good. And it's small figures. It's not just the big, millions of dollars. They're now really finding things that are $1,000, hundreds of dollars here and there, because some of those little ticket items add up. Okay, so hopefully that was helpful today. Now you know what a QHP is. You're understanding the ACP billing. And I hope that was helpful. So everyone, make it a great day, make it a great rest of your week, and thank you for listening to the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.